Hi, everybody. It's nice to be able to share my journey and my work with you today as the AOTF Mid-Career Research Awardee. My name is Beth Pfeiffer. I'm an associate professor in the Department of Health and Rehabilitation Science in the College of Public Health at Temple University. My current research focuses on enhancing community participation for transitional age youth and young adults with autism spectrum disorder and serious mental illnesses. Right now, I have a heavy emphasis on transportation and community mobility as well as in employment for this population. We developed a number of measures as well as intervention. I wanted to start talking about some of the lessons I learned in this journey. Certainly, the biggest one is that you can't do this work alone. I've had a number of incredible mentors along the way that really supported my work and supported my development as a researcher. And additionally, I spend a lot of time mentoring other people in their journey as a way to build up our science and occupational therapy. We need strong partnerships and strong research teams, and that has really been pivotal in being able to advance the work that we're doing. These partnerships really have ranged from other researchers to organizations, community-based organizations, to large organizations and such as transportation agencies. And these partnerships allowed us to direct our research in a way that would be meaningful and productive as well as successful in being able to obtain the information we needed. I think most of you know that a research team is essential, and this research team needs to at times be both cross-disciplinary, but also focused on the work you're doing together. So you're building that work as a group of people to be able to move that forward. And that has also been really pivotal in being able to advance some of this work. I've also found that the research significance is essential. We need to be able to communicate why the work we're doing is so important. And oftentimes people can understand this within the profession of occupational therapy, but we need to be able to transcend that and be able to communicate the importance of this work in other professions. I think our work is always important, so it's easy as an occupational therapist to be able to do this. Where it becomes more challenging is in the language we use. We need to be able to use language that bridges into other areas and disciplines so that the people that are reviewing our work, who are going to read our work, who are going to fund our work, really understand the meaningfulness and the impact that it can have. And finally, in all my work, I value the stakeholder voice as central. This is pivotal in being able to determine research outcomes and also meaningful work that's going to be used and implemented. So in everything we do, we have stakeholders involved in the development of the research, in ongoing implementation, and sometimes they're part of actually the research team itself. This is one of my favorite little cartoons over here. And this is about communication. All of this goes back to how we communicate and how we work together. And so this one looks at, obviously it's funny, and that's how we lift on three. If we are not on the same page and we're not moving towards the same goals, we're not going to be able to successfully implement and be able to get our research funded and be able to implement that successfully. My journey has really focused on three main areas of research. We've looked at the relationship between sensory processing and developmental disabilities and mental health. I spent quite a bit of time doing that type of research before I bridged into looking at measurement development and intervention. It served as a foundation for some of the understanding. And certainly it guided us in our basic premise that we're looking at measurement and measures and interventions that are focused on this idea of person-environment fit. So almost all of our research really goes back to what are the strengths of the person, what are the needs of the person in relationship to that environment, whether that's transportation work, whether it's employment work. We're looking at those factors as we look at how we measure that and how we are going to provide effective interventions. We have another line of research that's specific to measurement development. Some of these are outcome measures, some of these are measurements to guide interventions. And I'll talk about one of those projects today. We also have done quite a bit of work in looking at targeted interventions that are person-centered and environmentally focused to look at whether they are effective, whether they have efficacy. Additionally, we have looked into really developing interventions that can address some of those person and environmental factors. I will talk about a couple projects with that as well today. Here's some information on some publications and external funding to support some of our work with sensory processing. There's another slide that looks at our work with measurement and where we've taken that and our funding sources as well. You can see in our funding sources, we have kind of a diverse group of funders. We have a number of federal grants that support our work currently. But as we built up to the work that we're doing, we've really looked at some of those pilot grants, which were foundational grants. Certainly AOTF has been very supportive of us in that process with pilot grants, as well as other foundations. And that's where we needed to start to be able to get to some of the larger studies that we're working on today. And finally, here's some of our publications, recent publications, and external funding for some of the intervention work we're doing. So today I'm going to talk about some of our work with transportation and community mobility. I'm going to touch on some of the pilot work that we needed to do prior to getting to the intervention work that we're doing now. And I will talk about a project we have ongoing that looks at enhancing community participation for adults with autism spectrum disorders through peer-mediated transportation interventions. We have another project that's very similar to this one that focuses on serious mental illness. I'm going to talk a little bit about our Photovoice studies that we're implementing currently, and then finally about an employment-focused measurement work that we have doing that's multi-site. So in looking at transportation and community mobility for individuals, we really needed to start with studies that helped us understand what this looks like for this population. And we also really needed to understand the impact that this has on individuals with developmental disabilities and serious mental illness. This is from another study that another occupational therapist completed, where it's a great quote: "If you don't have access to transportation, you don't have access to a whole lot of things. You don't have opportunities to do very much, and you become very limited." We know that transportation serves as a significant barrier. The lack of accessible transportation represents one of the chief barriers to participating in economic and community life outcomes. Much of our transportation work stemmed out of the work we were doing with employment. What we discovered in that work is that transportation was one of the main barriers to employment. It serves as an important barrier in accessing services in the community as well. This can include healthcare, as well as employment services for individuals with intellectual and developmental disabilities and serious mental illness. We also know that transportation or lack thereof results in dependence on others to meet people's transportation needs. So not only does it impact what an individual with a disability is doing and how they're participating, it also impacts parents and caregivers and other people. A past study identified that 72% of individuals with a disability missed at least some of their desired activities due to lack of available transportation, whereas 70% of parents and caregivers missed at least some of their activities due to the responsibility of transporting their adult children. Community mobility. This is really a way that we frame this idea. We use transportation for community mobility. It is our primary outcome. People be able to get out in the community and fully participate. We find that in this population, there's a heavy reliance on use of paratransit services to access the community. And now this may be important for a number of people, and certainly we need to value the fact that it's available to people with disabilities. But it often can be more costly and an inconvenient option. People need to schedule this almost 2 hours before and 2 hours after their appointment time. So an appointment that might take a half an hour, in order to get there using public transportation and paratransit, and to get home, you might have to schedule a 5-hour period of time to be able to participate and get to that doctor's appointment and to the activity that you're trying to get to. We know that fixed route public transportation is more affordable, and it's also much more flexible. A person can look at the time schedules for that, and they can plan their trip accordingly. And they can go more than one place as well. Our pilot studies that we did prior to our intervention work really focused on understanding what the transportation patterns are of individuals with developmental disabilities, so that we could better understand the needs and the supports structure needed. Additionally, I'll talk a little bit about a curriculum, a program intervention pilot that we did. So we completed a community mobility survey. We wanted to understand the types of supports and services needed to improve access to public transportation and reduce these barriers. So we looked at the types of transportation used, the barriers, and the impact on community participation and employment for individuals with developmental disabilities. We're still collecting data for this particular study, but we did analyze preliminary results. Our methodology was a cross-sectional descriptive design utilizing survey research. When we analyzed the data most recently, we had 214 individuals with disabilities. They were aged 18 or older, or their proxies completed an online Qualtrics survey so that we could acquire information about basic demographics, transportation schedules and use, self-determination, participation, the amount of assistance required, the transportation barriers. We analyzed the data. We stored it in Excel, and we used descriptive statistics to analyze just mean frequencies and percentages for this descriptive study. So a little bit about our participants, very briefly. We had more males than females, which we expected due to the nature of the population. We did have a fairly large range of ethnicity and race in our study, but we did have a large majority were white. Our mean age was about 26, 27 years of age. In terms of the total sample, we had about 60 proxy reports out of the 214, and most of the time it was the parent who completed it. In the other situation, it was the actual participant who completed the survey. Education level was highly skewed to high school or equivalent. We did have a substantial amount of our participants were autism spectrum disorder, and that's why we're continuing to collect data. So we'd like it to have a better representation across the board of disabilities and other intellectual disabilities. That probably is because much of our other research has been focused on autism spectrum disorder. So targeting that population, people were much more familiar with our work. Interestingly, we did have a large population of urban and then suburban and the rural, what we anticipated. The regions we were nationally represented, with the most heavily represented area being the northeast part of the country. Just wanted to provide a little bit of information on and an overview on some of our findings for this study. We did have a majority of participants identify that lack of transportation limited their participation in activities in the community. And also the majority identified that they wanted to use public transportation to increase their participation. And they felt that use of public transportation in particular could improve their overall quality of life. We wanted to learn how many people were using paratransit and public transportation use in general. About 50% of our participants used paratransit services. And the majority of the people in the study had an opportunity to use public transportation. This did not mean that they used it on a consistent basis, and this also included paratransit services. So they had some experience using some form of public transportation, whether that was a bus, a train, or actually paratransit. The biggest barriers to the use of public transportation, this did not include information on paratransit, just on public transportation, was often that they felt like they did not feel safe, did not go close enough to where they were going, or they did not go to where they needed to go. And when we asked what kept them from actually using public transportation, many folks reported that they didn't know how to use the system. A number of folks reported that they didn't feel safe using the system. And sometimes it was about the schedule of the available transportation as well. This information did help us understand, though, that if we provided additional supports to learn how to use the system or how to feel safe using the system, that people might be more willing and interested in using public transportation to participate in their communities. Desire for training, the majority of folks identified that they would like to learn how to use public transportation and have the supports to do so. So obviously there's always a number of limitations when you're doing survey research. We had the majority of respondents had ASD. I feel like this was a fairly small sample size for survey research, and that's why we're continuing some of our data collection. So in conclusion, we felt that the study at least provided some important considerations for us to understand when thinking about participation and use of public transportation. We identified that there was a desire to use the transportation and people felt that it would be a benefit, and that specialized training was recognized as important. So this helped guide in our thinking about some of our future studies, which I will talk about in a few minutes. So as we continue to think about how we wanted to support people in using public transportation for community mobility, we really needed to have an understanding of what might work and what might not work. And we have the philosophy that we believe that stakeholders need to be integral to the research process and certainly to any interventions that we're going to develop or provide. So we identified a program that was developed by the Kennedy Center. It's a travel training program specific to individuals with developmental disabilities, as well as individuals with autism spectrum disorder. We wanted to see if this program was effective so that we could use it in integrating this curriculum into some of our interventions. So this study really examined the impact of a comprehensive travel training program that was implemented by the Kennedy Center. It included a pre-test, post-test scores on a travel skills assessment, the progressive evaluation of travel skills, as well as looking at the modes of public transportation that people used and the purpose of their use. And we wanted to know about dosing as well. So we looked at the number of training sessions that were typically required for that person to meet their goal. Data was de-identified, and this is essentially a secondary analysis. So we were looking at information that they had collected pre and post test for their travel training curriculum with a number of individuals. We also wanted to look at the effects of condition. We looked at how people's scores change pre-test and post-test if they had an intellectual disability without autism, if they had an intellectual disability and autism, and if they had ASD without an intellectual disability. This just provides a brief overview of the curriculum that they used. The curriculum really focuses on some of these core components that you will see again in the study I talk about in the near future. It really focused on helping the person learn how to interact with individuals in the community. It focused on those traffic symbols and signs, pedestrian safety, and surrounding awareness, that idea of safety, preparing for the trip itself. How do you get ready to plan your trip? There was some travel practice, and then what to expect about the what ifs for those things that are unexpected. And then individual travel training, this is really that one-on-one component of going out with the person and supporting them to be able to get to the place that they want to go in the community using public transportation. The results of our study identified that most participants traveled primarily by bus, with 6% traveling by train. The most common reasons that they used public transportation were to travel to work was the primary reason, that was 38%, followed by leisure activities, then school, and then finally general purposes. This might be going to the store, going to a doctor's appointment, maybe it was a church event. On average, trainees participated in about 6 sessions, each lasting 90 minutes. So that was about a total of 10 hours of travel training. We did find that trainees across the board made substantial gains on competencies needed for independent travel. We did find a significant condition of time interaction observed between the groups we looked at. We found that prior to travel training, people with IDD, with and without ASD, had less developed travel skills than those with ASD and no IDD. But interestingly enough, with this particular curriculum, those with IDD made larger gains in general in travel skills than those with ASD and no ID, such that at completion of the training, both groups had comparable levels of skills. We found that was an important piece for us to understand and know, so that when we're thinking about our targeted populations for future studies and in using this type of curriculum, that we would know what would, that we could use it across people with ASD and those with, that also had intellectual disabilities as well. Those studies were pilot studies for the studies that we have going on now. We have 2 projects in particular that are funded by NIDLR, the National Institute on Disability, Independent Living and Rehabilitation Research. One is a field-initiated project, which I'm going to talk about today, and the other one is part of a Center grant, which is a very similar study to the one we are talking about today, but it's with individuals with serious mental illness. The project with individuals with serious mental illness not only looks at public transportation, but it also looks at bike share, as well as a public transportation arm of the study and intervention. And then we have a transportation resource control group. Our theoretical foundations for really thinking about our research and the work that we're doing with these particular projects. We really feel that peer interventionists provided a mechanism of change in this role model. And we theorize that it enhances transportation self-efficacy. So if you have somebody that you can relate to and that is able to perform these skills, that you'll have more self-efficacy, a greater belief that you're able to do this as well. So we really, for both of these studies, we have peer interventionists that are implementing the one-on-one interventions and supporting the intervention process throughout. We also believe that community mobility is essential for overall quality of life, employment, and community participation. And as I said before, we really value stakeholder involvement as essential to implementing meaningful interventions and obtaining targeted outcomes. So not only will you see that we use peer interventionists, but we also have people on advisory boards and our research teams that have lived experiences with either autism or serious mental illness. So I'm going to specifically talk about our study for individuals with ASD, autism spectrum disorders. So essentially our design of the study is that it's a block randomized control trial. So as we recruit participants, we usually recruit 8 participants at a time. 4 of them are randomly assigned to our transportation resource group, which is essentially our control group. But they do receive some information about transportation. It's a resource manual. And they also have weekly phone conversations. And this is not to necessarily give them additional interventions or resources, but it's really to see where they're traveling or how they're traveling in their community. And then we have our peer support, our peer interventionist travel training group. The study is powered for 64 participants, 32 in each group. We have planned enrollment and recruitment at 80 to account for 20% attrition. Our participants in the study have to be 18 years or older and have documented diagnosis of ASD. That could be through something like an NDE or a previous IEP or psychoeducational or medical document of some sort. They must also score 65 or more on the RITVO Autism Asperger Diagnostic Scale. This is a self-report measure that assesses autism symptomatology. And 65 is determined in the cutoff for that. To ensure that participants are safe enough to participate in all aspects of the travel training, they also must score a 28 or above on the Transportation Pre-Screening Assessment for Inclusion. This is an assessment tool that was part of the Kennedy Center curriculum, and it really looks at whether somebody's ready to participate in that one-on-one travel training where they're going out into the community. There's additional interventions to prepare people for their readiness to go on to the next stage, but we weren't focused on that particular group at this point in time in this study. So we were looking at people that could score 28 or above. They must also be able to access a fixed bus route or rail station within 3/4 of a mile of their home for departure and destination locations to be able to be included. And that's really about just accessibility. You know, do they have a place that is accessible to them, that they could take public transportation. Participants who had any prior training or exposure to this particular curriculum or who are using public transportation independently are excluded from this study. Our peer interventionists are peers that have a diagnosis of ASD. They are hired as staff members in the studies. They are part of our team. We have 1 full-time and 1 part-time person that's hired for the study. The full-time staff completed what they call the Certified Autism Peer Support Specialist CAPS training within the City of Philadelphia Behavioral Health Program. So this is a new peer support specialist training that is offered in Philadelphia. I know that not many other places have this, but it really allowed specific training in how to support other people with autism to be able to meet goals, and what it also allows us to really look at what peer support means. They had to be independent and consistently use public transportation for community mobility. They needed to complete a comprehensive training program that we developed on the curriculum and also study implementation. And they also receive ongoing support from clinical staff. So that's really where we embed our occupational therapy supports. We embed it in support for the peer interventionist, as well as parts of the intervention process that are offered throughout the curriculum. These are our procedures. We did random assignment. The intervention group that receives the actual peer support intervention receives 6 weeks of the peer-mediated travel training intervention using this Chance to Ride curriculum. They meet 2 times in each of the first 2 weeks with clinical staff and peer interventionists for direct instruction and role play experiences, and that covers 6 core components of the curriculum. The last 4 weeks of intervention are spent in individual travel training instruction provided by the peer interventionist, where they take 3 travel trips each week for a total of 12 travel trips. And the dosage was based on that pilot study that we had. We wanted to make sure that they had at least 10 hours of instruction, and we enhanced that a little bit based on that as well. Clinical staff and peer interventions complete logs to track the dosing that we're using for this particular study. And we're looking at the average amount of intervention needed to develop independent travel skills and to meet their goals that they established as part of the study. And we wanted to look at also characteristics associated with the amount of intervention needed to develop independent travel skills. So we're going to be able to look at demographics in relationship to how much time was needed to meet their goals. Once again, this is the travel training curriculum that we use. You can see that the first aspects of this, that interaction, the traffic signs and symbols, pedestrian safety, preparing for trip, and some of the travel practice, as well as unexpected dealings with the what ifs. We introduced those constructs and concepts with this in that initial 2 weeks. And then we really heavily focus on that one-on-one travel training where we can talk about some of those concepts again when we're actually implementing the travel intervention one-on-one. We developed a fidelity protocol, which includes the information we're collecting to determine if we're maintaining fidelity to our protocol, includes interviews with the peer interventionist. We maintain clinical and peer interventionist logs as well for what happened in the session and what is taking place. Also, we have observations of peer-mediated intervention. So a clinical staff or myself observe at least one intervention session for each participant during that one-on-one travel training. We have a fidelity checklist to guide the observation. And the fidelity checklist focuses on those key components essential for integration of the intervention across peer interventionists. So it includes both components of the travel curriculum as well as these peer support components that we expect to be present, that we need to be present for this idea of self-efficacy. So our outcome measures, we use descriptive data. Obviously, that's not an outcome measure, but it is information that we want to obtain about our participants. We have a general self-efficacy scale we use. We have a transportation appraisal scale, and that scale looks at essentially transportation self-efficacy. We use Temple University Community Participation Scale that looks at participation in the community. We have them complete daily transportation and participation questions so we know what type of transportation and also where they went and how they participated. We use GPS tracking, so they each have a phone for the 2 weeks before the intervention and the 2 weeks after, so we can track their travel patterns and what type of transportation they use. There's a transportation support scale, caregiver transportation scale, and essentially this is measuring this idea of caregiver burden that has been so extensively reported in past research. We found that caregivers really don't like the term burden, and they don't want to be thinking about their significant others as a burden by any means. So that term might not be the most appropriate, but it's certainly this idea of the effort that they need to put in or the sacrifices that they need to put in to be able to transport their loved ones. And so we want to know if that changes. We have an enthusiasm and support scale, which looks at how hesitant or how eager they are about using public transportation. We also complete qualitative interviews with both peer interventionists and participants after post-tests. And what we want to know is we really want to know more information about the intervention itself and how they perceive that and the acceptability of the intervention. And then finally, one thing that's not listed here is that we use goal attainment scaling. We focus on outcomes that are meaningful for the person. So these goals are set in collaboration between the clinical staff, the peer interventionist, and the participant in identifying what is important to them, how they want to use public transportation, and what they want to use it to do in the community or for their overall participation. So we collect data at pre-test, and then we have a post-test, which is immediately after the intervention completed, and then we have post-test 2, which is 4 months after that. So where are we now? We are in the middle of the study. So far, we had a really good response from participants, and they were very eager. I've never had the situation happen before where recruitment was so easy that they're coming to us. So it suggests to me that transportation and community mobility is really an important area for this population, and people value it, and they are searching out possible supports. With that being said, we have 44 people enrolled. We have 44 people that completed pre-testing, We have 36 that have completed post-testing 1, which means they completed the intervention. Our retention of data so far has been 96%. We believe there might be a little loss in GPS data, but it's very high. And for the post-test 2, we have 16 people that completed a 4-month follow-up. Interestingly enough, we're at a place where we're on hold because of the public health pandemic that we are experiencing right now. We anticipate that this might change our recruitment and our interest in participation, but I'll talk about the plans for that in a few minutes. Just a little bit of information about the study right now. The people that are participating, we have a mix of race, with the majority being white or Caucasian, and then followed by Black or African American, which represents the area that we are located in. We have, in terms of community type, we have more people that are suburbanites. We actually thought we'd have more urban people because of the use of public transportation, but we have the most are suburbanites, and then we have people who live in urban areas, and then of course far fewer that are in the rural communities. And we anticipated that that would be the case because we're looking at people that have access to public transportation. The majority of our participants have been male, which is typical with ASD, and our age range has ranged from 19 to 32 with a mean age of 24. We don't have data organized to share regarding the participants or peer interventionist experience as of yet. We have that information, but we haven't analyzed it yet. We did get some feedback though from caregivers at this point that I thought would be interesting to share, and they shared with us about the benefits of participating in this study for them as caregivers, and some identified that it was just a really important topic for their child to learn. The independence of it is priceless to me as a caregiver, that my son has access to transportation, that they're more confident about using transportation and commuting to work, that they hope that this will evolve into a training that can address the needs of multiple people with IDD, and then some identified that they had more alone time at home for their spouse and them. When they identified what they thought was important for participating in the study for their actual loved one, they said that gaining independence was a big one, and just their sense of pride, that they were very proud of themselves, and that was good for their self-esteem, that knowing how to use public transportation will make them more independent, that their loved one is more motivated to get out and use public transportation to go more places, and that they're starting to meet new people. So these are some really substantial qualitative pieces of information. We certainly have a lot more information to collect and also analyze, but we thought these were interesting quotes, and certainly what we would hope for some of the outcomes that we're looking at. We have proposed some additions. We're trying to take advantage of this time where we needed to stop data collection so that we can physically distance from one another and protect people's health and well-being. So we are not able to implement our interventions right now, but we are going to track the data before and after COVID-19 to see how that changes participation in this population and community participation and use of transportation. We're in the process right now. We're using this time to develop additional curriculum on how to use public transportation safely with public health concerns such as COVID-19. We're working with some of our colleagues in public health to add components to our travel training curriculums, and also to training for our peer interventionists. And we're thinking about how we're going to collect future data. We have thought about kind of optimizing the potential lulls. We know that this is probably a public health concern for the next 18 months, and that there might be time periods that are safer than others to collect data. So we're in preparation to make sure that at those points and times we'll be ready to collect more data and using those times of safety. I also wanted to share just a few minutes on our Photovoice projects. We were funded by a local organization, Brandon's Voice, which is a nonprofit organization committed to helping individuals on the spectrum have a better tomorrow through targeted action. And really their main focus is that we need to listen to more closely to what people are saying who have autism spectrum disorders, and that they need to be part of this. So it aligns with our keeping the stakeholders' voice central very well. And so they were very supportive of our proposal of a Photovoice project. Photovoice was developed in 1992 by Carolyn Wang and Marianne Burris as a way to represent how women in China who lived in a small village represented their daily lives living in poverty. And it's been expanded substantially over time to look at other populations and other experiences. It's a research strategy that encourages participants to use their photos to answer important questions about their lived experience. And it gives the participants an opportunity to teach researchers and policymakers about their perspectives. And so we feel this is really essential in understanding how to best support individuals with autism and other developmental disabilities. So we're implementing a Photovoice project that's planned for the summer of 2020. And we hope that we'll still be able to do that. Participants will attend 7 sessions around learning how to do photo voices. They'll be given cameras through either phones, digital cameras, or iPads, and they'll be asked to answer questions. These aren't quite finalized yet, but really surrounding transportation. What does transportation mean to them? What's helpful in being able to use transportation, and what are challenges or barriers, and how has it changed their lives? So we are working on developing the modules for the Photovoice component of that currently, and we're going to put them on an online platform as well as an in-person platform. This is an example of a research question and how you might answer that. How does travel training impact the quality of life of participants and peer interventionists? So these are some photos that a participant and our peer interventionist took when they were together. It represents a travel training session they had. You can see the 2 people in the picture above are our peer intervention and the travel participant. They were very motivated and eager to learn how to independently travel. He would, in the past, ride his bike around the community, but was limited in his radius. So he's very limited to his immediate area that he could get his bike to. Through travel training, both the peer interventionist and participant learned how to travel in around Philadelphia areas that they hadn't traveled to before. They found common interest and went on many adventures together. And one of the biggest accomplishments was that the participant learned how to put his bike on the train, which you see at this bottom picture, where they were able to use the bike to get to different places, and then also take the bus and then use that bike to explore other places when they got there. And they've started to use that to meet at coffee shops and so on before our recent restrictions. We are also proposing an additional study that really examines some of the experiences that people might be having with COVID-19 pandemic. We're doing a very fast-tracked IRB. Our IRB has agreed to fast-track this. And we're going to look at the use of Photovoice to examine participation for transitional age youth with ASD and their lived experience during COVID-19. We're hearing from many families and many individuals that this has been an extremely challenging time for them, especially in terms of making connections and also their loss of support structures that they usually have in place. So we should be starting that study in the next few weeks. Finally, I want to just talk about our last project, and I'm really excited about this project. This is another one that is ongoing. We just started. This is a multi-site project with Colorado State University, University of Florida, and then Temple University. And we're really looking at expanding the use of the Vocational Fit Assessment. The Vocational Fit Assessment looks at finding the right person fit with the environmental characteristics of the job. So it has that person-environment component. This was originally developed by Dr. Andy Kirsch and Dennis Leary, who have now taken this to the next level and we are working together with them as a team. It's a really good example of team research in order to expand the use of this tool and measure. It's funded by an R1 through NICHD, and the project is titled Vocational Fit Assessment and Employment Status in People with Intellectual Disabilities. The Vocational Fit Assessment is the first measure of employment status outcomes to utilize common item stems for the assessment of worker abilities and demands in the job. And the questions really, they can target the worker or they can target the job. And they're really looking at, to what degree does the worker demonstrate the ability to have the skills necessary for that job? And you can see a sample of a question here. And then also, to what degree does the job demand fit with the strengths of the person? And this is the way it is looked at, is it looked at in terms of ability. So you have, does the worker demonstrate the ability to, and it's that common stem with a specific skill. And in this situation, it's to communicate face-to-face with other people. Do they have a high ability? Do they have some ability or a low ability? And then if you're looking at the job characteristics, to what degree does the job demand, and that's the common stem, the ability to communicate face-to-face with other people? Does the job itself require a high demand, some demand, or low demand? And then they're looking at, there's a complex algorithm that they have developed over time, and it allows people to really identify, is it a good match in terms of abilities and demands of the job? Excuse me. And you can see there's the green where it suggests that, yes, so this is a good match. There's the yellow that the match may not be perfect, but it certainly could be improved. So if you have an individual who's really interested in a certain job and that they would like to pursue that as employment for themselves, that with additional supports, that's where the supports might be targeted or needed so that they could succeed in that. And it's certainly never suggesting that a person can't do that. It's just suggesting that this is the amount, there might be supports needed. And then certainly orange and red, you can see that they would need substantial supports. Once again, it never suggests that you shouldn't do that job. It just suggests that you would need some substantial supports to be able to perform that job. You can see here's our research team. I wanted to end with a study because it really shows you this idea of team research and collaboration and this idea of interdisciplinary work as well as work within our own profession. The three PIs on this project, we are all occupational therapists, but we're working with a number of other people that work in other disciplines as well. So the project is, we have Colorado State and Temple University. We also have Cincinnati Children's Hospital where Project Search is located, and they are some of our primary team members. Of course, University of Florida as well, and then Indiana University. So we have quite a diverse representation from various areas of the country. Thank you very much. I feel very honored to have been awarded the Mid-Career Research Award and to be able to share this work with you today. And I wish you all good health